All right. Well, welcome everyone. Thank you for joining us for today's Nutrishare Neighborhood. My name is Michael Medwar. I'm Nutrishare's patient support specialist. Today's topic is the latest in PN troubleshooting with our co-presenters, Vanessa Sumner and Elena Stoyanova. Vanessa will be discussing issues with hardware like filters and pumps and occlusions, and Elena's going to dive into central line issues and information on the internet, which is something I think everyone uh, can can relate to and has been there for to look for information. As a former longtime home TPN patient myself, I think this topic is important because uh, managing home intravenous nutrition on a daily basis is so complex. And yes, we have people in our community who have been on therapy for years, decades, even, who maybe have even quote unquote mastered therapy to some extent. Still, any consumer or caregiver can run into issues that they've never seen before, or maybe they have an issue that it's been so long that they've come across a certain issue that maybe they've forgotten exactly how to handle it. So when issues do arise too, how many of us default to the internet to look for information, look for answers? So the purpose of this program is to give you some tools to keep you and your loved ones educated and safe as possible. A little housekeeping note: everyone's medical situation is unique, so please consult your doctor, home infusion provider, other qualified healthcare professional before making any changes to your nutrition therapy based on what we covered today. We welcome your perspectives and questions in the Q&A. Please try to keep those general, and we will answer them at the end of the program. Leading off today is Vanessa Sumner. Vanessa is the Senior Clinical Specialist for Moog Medical Devices. Vanessa started her career in nursing at Intermountain Medical Center in Murray, Utah, specializing in cardiovascular nursing, heart failure, and heart transplant. In 2020, she worked for Ameritech College of Nursing as a clinical instructor, where she grew to love educating future nurses. She joined Moog in 2020 as a clinical training specialist. Vanessa leads global education initiatives for Moog medical employees focused on infusion and enteral nutrition, and leads continuing education programs and webinars for clinicians seeking advanced knowledge in those areas. Welcome, Vanessa. Take it away.
Thank you so much for the introduction, Michael, and thank you
You're
everyone for
welcome.
joining today. So, when infusing TPN or, if you're infusing any other medication or fluid, we know that there can be a lot of challenges, right? Your infusions should be able to fit into your lifestyle, not be a burden that you need to spend a lot of time working on. So I hope to help you walk through some common alarms and provide you with some resources and knowledge to help you troubleshoot, specifically when using your pump and administration sets. Okay. So the first alarm that I want to talk about is the air in line alarm. I'm sure you all have had an air in line alarm. This is where the pump has detected excess air in the tubing. Depending on the pump and the pump sensors, this could be one big air bubble, or it could be kind of a buildup of multiple air bubbles. Now, there are a couple reasons that air bubbles can accumulate in the tubing. So I'll talk about some of those reasons, and then we'll talk about how to kind of troubleshoot those. Okay. The first can be from just priming the tubing. So removing all of that air from the tubing, if you don't do it correctly, can actually cause some air. So priming the tubing too quickly can cause turbulence. So think of like flying in an airplane. What is turbulence? It's basically rough flow. So the fluid moves too quickly through the tubing, causing swirls and friction, and this creates air bubbles. Okay. Another reason comes from the cold temperature of your TPN. So you get your shipment of TPN, you store it in your fridge as you should. And then when you take that nutrition out of your fridge and you warm it up to room temperature, you'll notice it can create air bubbles. This is normal. It's a physical property change within that mixture. So keep that in mind. There's nothing wrong with your TPN if you notice those air bubbles as it gets warmer. One thing you may want to check, or you can ask your pharmacy about, is the air sensitivity setting on the pump. Because you might not be able to avoid all of these air bubbles, okay? But you can decrease the amount of air in line alarms that you receive on your pump, especially if you're infusing at night. You know, you don't want to be waking up to those alarms, or during the day if you're going about your day and you have to stop what you're doing and, troubleshoot your pump. So your pharmacy may be able to adjust the air in line setting so that it doesn't alarm as often. If the air sensor on the pump is too sensitive, again, you'll get those alarms more frequently. But we would never recommend to turn the air sensor off, as it is a safety feature, okay? So here's what we can do to help decrease those air in line alarms. The first would be when you're priming your tubing, prime it slowly to help avoid that turbulence. Using the prime feature on the pump will prime that line at a smooth, steady rate, okay? You can prime the tube manually. I know people do that without having to use the pump, but just be careful that you're not, squeezing that nutrition bag and you're trying to go as fast as you can and force that fluid down too quickly, okay? Because that will create air bubbles, which is what we're trying to decrease. Also, make sure to give yourself plenty of time for your nutrition to reach room temperature before you prime and infuse, okay? If the tubing is primed while the TPN is still cold, then that cold TPN sitting in that small tubing, I have some tubing here, right? That cold TPN sitting down here in this small tubing, it will still off gas as it warms and create those tiny air bubbles, okay? Those little trapped pockets in the tubing, they can expand and break into smaller little air bubbles as well. At that point, especially if the bubbles are past the pump and even past the filter, if you've primed the whole line, you may have to prime out additionally, prime some more and get out the rest of those air bubbles. Oh, sorry, Michael, could you move to the next slide here? Thank you. I didn't say that. There you go. Especially if you have those little air bubbles in your tubing, in the end of your tubing, you may need to disconnect your catheter and prime so that you don't get those air bubbles into your system, right? So make sure if you do have to disconnect and prime, that you know how to do that correctly, especially if you're out and about, you have supplies with you that you can disconnect safely and make sure you're using aseptic technique, or if you have a caregiver with you that might be able to help as well. If there are air bubbles in your bag or even in your tubing, the filter on your TPN set is an air eliminating filter. So no air should get past that filter and travel down to the patient. However, the filter needs to be completely wetted and primed correctly in order for this to happen. Okay, next slide, Michael. So if you have been infusing TPN for a while, you might have noticed some changes regarding filters and what exactly a filter is needed and used for in parenteral nutrition. But the most recent one in 2021 was from Aspen, the American Society of Parenteral and Enteral Nutrition. They posted a position paper on the use of filters for TPN. And there was a lot of great information in that paper if you haven't had a chance to read it. But to summarize, Aspen does recommend using a 1.2 micron filter with every parenteral nutrition infusion, okay? This is recommended for a few reasons, but the biggest concern being those particulates in the admixture. So as you know, TPN consists of a lot of different additives, which can potentially generate particles, okay? And even if you're having to use different vials and syringes, to mix up your nutrition, that can always accidentally add, some other additional microscopic particles to the mixture. So if you've been infusing TPN for a while, there was probably a point in time where you would use your 1.2 micron filter for lipid containing, and then your 0.2 micron filter for anything else. But now the blanket statement is that 1.2 micron filter for all TPN, okay? But using a filter will trap those particles, and if there's, potentially any other pathogens like bacteria or fungus from entering your bloodstream. Many administration sets have an inline filter, meaning it's like this that I have here, where it's integrated into the tubing. However, there's many filters you can see on the slide here. And I know sometimes with supply shortages, supply chain issues, maybe sometimes you've had to add on a filter, okay? So you might have received a filter that's new, or you don't know how to use it. This looks different than what I'm used to, okay? So if that happens, just make sure to read. There's always instructions that come with it. Make sure to read those instructions. Contact your clinical team, contact the manufacturer of the product too, to make sure that you're going to use it correctly. Okay. Next slide, Michael. So a little bit more about filters and kind of how they work. This is really interesting, at least to me it is. And it's helpful to see if you're using this product, what exactly is going on. So a filter is manufactured with an outside housing and an internal membrane. So if you look on the screen here, kind of on the left under where it says how filters work, we'll talk about this specific picture a little bit. But the membrane inside is what measures the micron pore size. So you can have two filters that are the same size when you're holding them. So like right here, if you look at my camera, these two
Can I
filters are,
spotlight you for a sec?
oh, perfect. That'd be great.
Yes.
Thank you, Michael.
Okay.
So if you look at my camera, these two filters, they're the same size, but inside that filter membrane is different. One is a 0.2 micron, one is a 1.2 micron. Okay, so just because they're the same physical size doesn't mean they're the same micron size. Okay, so if you've received a new product, just make sure to double check that it's the micron size that you need. Okay. Now, how a filter works is as TPN fluid enters into the filter, it must be completely wet. It must completely wet that membrane inside, that little kind of paper inside. So on the screen, you see kind of the filter and there's like a yellow squiggly line that represents that membrane, okay? Now to correctly wet this membrane, some filters might need to be inverted, okay? Meaning you hold it so it kind of comes down and then you're holding it kind of upwards, pointing towards the ceiling, okay? While some other filters, to make sure that they're filled completely, some say kind of swish it back and forth like a windshield wiper, okay? So just double check the filter that you're using. If that membrane is not completely wetted, then you can have a dry portion where air can pass through and end up in the tubing past the filter, okay? So prime your filters correctly and prime them slowly to ensure that the filter is filled properly and it's safe to use, okay? So I'm just gonna kind of demonstrate a little bit really quick, and I'm using the Curlin pump. I know some of you might have that, some of you might have a different pump, so always double check with the product you have, okay? But I'm just gonna kind of demonstrate because I've heard some people say that they get their pump, they have their medication, and then they just kind of lay everything on the table and they prime that way, okay? But if your filter for this particular filter, if it's laying down like this while you're priming, it's not going to prime correctly. Okay. For this particular filter, it does have to be inverted. So that arrow is pointing up towards the ceiling. Okay. So what you can do, I know sometimes it feels like you have to have a lot of hands, right? So you can lay your medication, your pump on the table, and then just kind of dangle that filter off and hold it so that it's pointing up towards the ceiling. Okay. So I'm just going to quickly prime my filter here so I can demonstrate for you. And I primed a little already, so it's not going to take as long as it sometimes does, right? But I know it's hard to see on camera. My filter is slowly filling up. Okay. And then once that's completely wetted, you can kind of watch it too as you're priming. You'll see the fluid kind of travel up the filter. Okay. Now it's completely wetted and the rest of the fluid starts to flow down. Okay. So that might be a good little tip there to kind of help it hold the filter with one hand pointing up, press the prime button with your other hand. Okay. But I want to discuss something else real quick while I'm spotlighted is let's talk about bolusing. Thanks, Michael. Yeah, go ahead and keep me spotlighted. Okay. Because my filter here is completely wetted. Okay. But bolusing is when a single dose of that drug or fluid is given all at once. And this can occur when you raise the air eliminating filter above the patient's catheter entry point. Okay. So if I were to, I don't have my slide clamp on, my slide clamp is nice and open. If I raise my filter up, I have to raise it a little higher here, it will start to empty. Okay. You may have had this happen before. You prime your filter, you prime your tubing, okay? And then you start, putting everything together, getting ready. And then you come back and you notice your filter is empty. You might be able to see it. Mine's starting to empty. Okay. That's bolusing. Okay. So if you're not ready to connect directly to your tubing and start going, close that slide clamp. Okay. That will prevent that bolusing. So you might be able to kind of see it now. My filter there's a line right there. It's empty a little bit. Okay. So that's just one tip to make sure that that your filter is properly primed. Okay, so once you're done priming it, if you're not going to connect directly, close that slide clamp. If you're ready and you're ready to get hooked up, no need, just get hooked up and run. That's fine. But if you're not, close that slide clamp. Okay. Thank you, Michael. You can go ahead and go back to the slides now, and we'll move on to down occlusions. Okay. So another alarm you've probably seen is the down occlusion alarm. This means the pump is sensing excess pressure in the line between the patient and the pump. Now remember, there will always be some pressure in the patient's tubing. So if your pump has a pressure line reading, as long as there are no alarms, you should be okay. Okay, you should have some pressure. But this alarm can occur for many reasons. But we're looking for a problem downstream, so from the pump down to the patient. And this can also even be in the patient's catheter. So first check for any kinks or clamps, like if you closed your slide clamp and you got hooked up and you didn't open your slide clamp, okay? It could also be the clamp that maybe comes out of your PICC line or your port or your Hickman or something. Make sure that that clamp on that catheter is open as well. Sometimes you may even need to inspect the dressing on your catheter and make sure the tubing underneath that catheter isn't twisted or bent. Okay, I've seen that happen. Sometimes it can also be the position of your tubing and kind of how you have things set up. If maybe the tubing is bent, you threw everything into your backpack and it's all bent up in there and kinked with all of your supplies in your backpack. Okay. So, if you keep getting those, make sure to pull it out and kind of take your tubing and stretch it out. Make sure there's no kinks or clamps. But there could also be a blockage in the patient's catheter or a blood clot. Okay. So do you know if your catheter is patent and flushes easily? Has your nurse been out to check it recently? When you hooked it up, was it kind of sluggish? Think about those things. There could definitely be a blood clot on that catheter that's blocking your PPN from going through. The last thing the last thing to check would be if your filter is clogged. Now, the filter in your tubing could be clogged. And I know this can sometimes be difficult to assess unless you have another tubing that you can disconnect that one and use another tubing. But sometimes with TPN, some of those particles can form even hours after compounding. So if you've checked everything else, your catheter's great, there's no kinks or clamps, maybe that filter is clogged. Okay, so consult with your pharmacy team if that's something that you might need to consider. Okay, but pumps, just like the air and line setting, they also have a downstream occlusion alarm setting. So for example, if you're infusing a viscous fluid like TPN, it can be a little bit thicker than maybe just some normal saline. It may be more likely to have alarms, and you would want that pressure setting that will allow more pressure to kind of build up before that alarm is triggered. So if your setting on the pump is too sensitive, you're going to get alarms much more often while you're infusing. If the pump setting is less sensitive, it will allow for more pressure to build up in the tubing before that pump's occlusion alarm is triggered. Okay. Okay, next slide, Michael. Thank you. And the last thing I want to talk about is accuracy. Okay. Have you had those instances where the pump said the infusion was complete, but there was still a lot left in the bag? Or maybe the bag was completely empty, but the infusion was still going. It said there was still some time left. Okay. Infusion pumps, like all technology, are not going to be 100%. I'm sorry to say that. They're not going to be accurate every single time. There are certain things that you can do to help that TPN deliver as accurately as possible. Now, there's always a little bit of variability, so check with the pump manufacturer what their accuracy variability is. Oftentimes for home infusion pumps, it's around 5%. Okay. But the biggest impact on accuracy is going to be what is called head height. Okay. You may not have heard that term. I didn't know that term until I started working for a pump manufacturer. But basically, pumps are calibrated at a certain head height. Now, this will be different with each pump, but I'm going to use an example of 12 inches. Okay, so if the pump is calibrated to a head height of 12 inches, that means when you place the infusion bag about 12 inches above the pump, that infusion will deliver more closely to that programmed infusion rate. So if you look at the slides, that cute little middle picture, you have the bag and the pump, and they're about 12 inches apart from each other. Okay. Now, if the bag was way up here, you might get an over delivery. But on the other hand, if you look at the other pictures, if the bag and the pump is way down low, you might get an under delivery. Okay. This head height effect happens because the tubing in the pump can stretch slightly. Okay. And when that fluid bag is positioned higher than the pump, that section of tubing inside the pump is under a bit more pressure, uses some gravity. Okay. And that extra pressure causes the tubing to expand and it fills more and pumps more fluid. When the bag is at the same height as the pump or even lower, that pump essentially has to pull the fluid, similar to kind of siphoning, okay? And that pumping segment might not fill as much, okay? So think of a solution where you're infusing your TPN. Is your pump on the floor and it's having the pump upwards? Or is it on an IV pole and it's pretty at that, good head height? Please consider though, and talk with your pharmacy team, what's going to be the most important for you. If you have your pump in a backpack and you want to go about your day and you want to be mobile and you want to do all these activities, you're probably not going to have that accuracy perfect. Okay. But it might be more important for you to be out and about. Okay. You're still going to get your infusion. It's still going to deliver. It just might not be 100%. Okay. But if you need that 100%, you might have to be attached to an IV pole and have your pump in your bag at that perfect head height. So talk with your team to see what's going to be best for you. Okay. Everyone's scenario is a little different. Everyone's infusion rates are a little different. Everyone's mobility is a little different. So talk with your team and figure out what's going to be the best for you. Okay. Hey, that was a lot of information. So I'm going to go ahead and kick it back over to Michael. Thank you.
Thank you, Vanessa. Thank you for that great information. I think the head height reminders are particularly important. I don't know if everyone thinks about that all the time, and it's information that uh, that I think if especially if you're in a mode where you're doing the same thing every day and something is not right with your infusion, the amount that's being coming through the pump, that is something to definitely check. So we'll come back around to questions at the end, Q&A, if you have any questions for Vanessa. And let's see, I'm going to introduce Elena, our next presenter. Uh, Elena serves as Nutrishare's Director of Nursing Services and Clinical Education. Over the past 14 years, she has built extensive experience across critical care nursing, nursing education, and home infusion, with a strong focus on evidence based care and quality improvement initiatives. At Nutrishare, she supports consumers and caregivers through education, advocacy, and patient centered infusion care. She is passionate about empowering patients with knowledge and confidence needed to safely manage therapy at home. I'd like to add that Elena will be co presenting two roundtables at the Oli Foundation annual conference next month in Madison, Wisconsin. And I'll tell you a little bit more about those at the end of the program. Welcome, Elena. I'm going to stop sharing so you can share your slides.
Thank you, Michael. Okay, can you guys see my screen?
Yes. Excellent.
Perfect. I'm going to turn off my camera. My video is lagging a little bit and I don't want to make the connection worse. So I'm going to turn it off. It's nice to meet everybody and I'm going to get started. Okay, so when we talk about troubleshooting central line complications, the complications haven't really changed. We still encounter infections, occlusions, dislodgements, all kinds of dressing related issues, just to name a few. What has really changed is how we access information. Consumers now have immediate access to websites, videos, discussion forums, and artificial intelligence tools. Today, we'll review some common central line complications, discuss appropriate responses when they occur, and explore how online resources can support education while at the same time keeping healthcare professionals at the center of decision making. So this slide represents a very common situation. A consumer notices something that doesn't seem quite right. For example, there is redness around the exit site. The concern arises at, let's say, 9 p.m. outside of clinic hours, and information is now available immediately to a bunch of online sources. The purpose of today's discussion is not to determine whether consumers should use these resources, because the reality is that they're out there and we already are using them. The more important question is how to evaluate the information being provided and determine when professional guidance is needed. Again, the way consumers access information has changed dramatically. In the past, and really not that far distant past, often we relied on printed materials, education handouts, phone calls, conversations with our healthcare teams. Answers were obtained during clinic hours or after speaking directly with healthcare professionals. Today, information is available almost right away. Consumers can search online, they can look at instructional videos, participate in discussion forums, or the latest and greatest, just use AI tools. That accessibility can be incredibly valuable, but it also introduces a new challenge, the quality of the information that we look at. So before we discuss where we turn to for information, let's review some common complications and how we think about them. So let's talk about how we categorize those responses to complications. One important point before we start, these categories are intended to be educational tools, not medical diagnosis. This is personally how I like to think about complications, even in my own personal life. What is considered routine, urgent, or emergent may vary based on the individual consumer, their medical history, their central line, and the guidance of their healthcare team. Ultimately, your provider determines how specific complications should be managed. The purpose of this framework is to help you recognize when a concern may require escalation and understand the level of response that may be needed. As we review a few examples, think about understanding the actions associated with each category. We have routine complications. These are really minor issues that do not require immediate attention. These are things that you can continue to monitor, again, just minor complications. But then we progress to urgent concerns. They do require timely communication with a healthcare professional, because if left unaddressed, they become an emergency. And then I would like to discuss a few examples of emergent complications, because these are life-threatening emergencies requiring immediate attention. Because the action you take is often just as important as recognizing the complication itself. So let's start with routine complications. I have a few examples on the slide, such as mild exit side redness, dressing that won't stay in place, minor issues with the line tugging. There are situations that can often be monitored at home and addressed by a minor adjustment to your routine and supplies. You may consult your home health nurse, you can talk to your infusion provider. This may also be an appropriate time to seek general education information about a symptom or concern. For example, mild redness may really be related to irritation from your dressing or from the antimicrobial disc that you're using. A dressing may not be sticking because it's summertime and everybody is sweaty, or maybe you're very active, or your skin just doesn't like this dressing. A line is pulling, and a simple way would be to just use the better securement device. The common theme is that these issues are generally stable and do not represent an immediate threat to your health or catheter function. For consumers, this is often the category where self-management skills become really important. You may adjust your securement device, see if there's something better that works for you, reinforce the dressing, request a new dressing, review education materials, just troubleshoot. However, routine doesn't mean that we ignore things. The question should always be, is the situation staying the same? Is it improving, or is it getting worse? Because if you have a little bit of redness and now it's spreading, there's drainage, there's pain, this is automatically a different category of complication. And when in doubt, always call your healthcare team. That takes us to what I would consider some urgent complications. They are concerns that have the potential to be very serious. So they need to be addressed. The examples I have here are exit site infections, skin irritation, and we're not talking just a little bit of redness. This is when the skin is blistering and starting to get open. It's turning more into a wound now. A catheter occlusion that's not being resolved with a saline flush using push-pause method. Those complications are different from routine ones because they typically require escalation and evaluation. There may be some basic troubleshooting steps that you can do at home, but always check with your provider. Of course, if you have an occlusion, you're always going to check your clamps, you're going to look for kinks. If you have issues with the skin under the dressing, you may look into different dressing, you may use a different prep product, or something I see very commonly, not allowing the antiseptic that you clean the skin with to dry. Again, there's options that you can implement, but if things have progressed to this level, you need somebody else to look at it. Because the expectation is here, we don't simply monitor and wait, and we should call provider first. And while you may learn more about what you're experiencing, that information should support, not replace, communication with your healthcare team. The goal is early recognition and early intervention before things become emergencies. And speaking of emergencies, here's 3 situations that I would consider emergency. They require very different response: bloodstream infections, air embolism, significant catheter damage or dislodgement. The common theme here is that those situations can become potentially life-threatening. You can see bloodstream infection presenting with fever, chills, confusion, low blood pressure, some other signs of just systemic illness. An air embolism, you can experience sudden chest pain, difficulty breathing, dizziness, loss of consciousness, all very serious symptoms. And significant catheter damage or dislodgement can create immediate risk for bleeding, infection, or an air embolism. And you can see how those situations, again, have the potential to place a consumer's life at risk. And unlike the previous categories, there's not much you can do before you have to take action. Sure, if your line is damaged, it's not all the way out, don't pull it out. If it's broken, you can clamp it. If you have air embolism, you can lie on your left side with head lowered and chest. But ultimately, you're ending up in the ED or calling 911 because the priority is immediate action. This is definitely not the time to search online, watch videos, ask ChatGPT what he thinks about your symptoms. This is the time to act because delaying care may and will result in serious harm. So now that I briefly reviewed a few complications and how to respond appropriately, let's shift our focus to where we often go for information when those concerns arise. And there's multiple sources of information. We have search engines, video platforms, AI tools, healthcare teams. They're all different entry points. For the remainder of this presentation, I want to focus on AI tools and online videos. The questions we'll explore is not whether these tools are good or bad, but what does evidence tell us about the strengths and the limitations of said tools? In a recently published study, Barrera and colleagues compared ChatGPT responses to responses written by experienced home parental nutrition clinicians, and then they asked practicing clinicians to evaluate both responses. And overall, ChatGPT performed well, and clinicians often preferred its responses in some categories. As shown on this slide, several themes emerged. First, ChatGPT frequently encouraged ongoing communication with providers, infusion companies. Second, it provided clear, actionable guidance. Responses often outline practical steps and explain how you can respond to common concerns. Then it promoted consumer empowerment through those step-by-step explanations and guidance. And fourth, it often explained the possible causes of a problem, helping consumer better understand what might be happening and why. And ChatGPT actually scored really high in empathy, which personally to me is not surprising because it has given me encouragement to do some really bad ideas. So it is really a beat even when the ideas are not that great. So taken together, these findings suggest that AI may be particularly useful in an education tool helping consumers understand concepts, reinforce teaching, and navigate common questions about their care. But there's always a but. While these findings on the previous slides were very encouraging, and they sure are, it's equally important to understand that there are limitations. While AI performed well for broad education and lifestyle topics, the same study found that clinicians' responses perform better in certain situations, particularly when questions involve more complex clinical judgment, such as interpreting lab results or addressing individualized clinical concerns. And this highlights an important distinction. Providing information is not the same as providing medical advice. For example, AI may be able to explain what a catheter occlusion is, describe common causes, review general prevention and strategies. However, determining why a specific consumer's catheter is occluded, what interventions are appropriate, and whether additional evaluation is needed really requires clinical assessment. The study also identifies situations where AI responded, including impractical recommendations, assumed level of knowledge that the consumers don't necessarily have, or placed too much emphasis on self-assessment. So for consumers, the concern is not simply whether the information is accurate. The concern is whether time is being spent trying to determine the seriousness of a complication when a call to a healthcare team needs to be warranted. So that kind of leads me back to my previous spiel about different complication, and that's where you need to really get to learn about, is something serious, and be able to make that determination yourself. Obviously, that comes with time, experiences, and guidance from your healthcare team. AI can be a valuable tool, but determination of severity, urgency, and next steps need to remain with the healthcare team, because there are dangers that you don't see. I looked at another study that addressed the questions, can users recognize the limitations of AI? And in this study, responses to common healthcare questions generated by ChatGPT again were compared to physician responses that had previously been posted on an online forum. And all of these responses were evaluated both by patients and physicians. And patients rated responses based on how useful they found them and based on empathy. But the physicians also evaluated if those responses can cause potential harm. And overall, patients rated ChatGPT responses higher than the physician responses from the online forum. And again, empathy and usefulness were front and center. However, one finding is particularly relevant to what I'm talking about today. As shown on this slide, physicians identified potentially harmful advice in approximately 5% of the ChatGPT responses. Interestingly, the rate was actually lower than the harmful advice identified on the online physician forum responses. The concern wasn't only how harmful advice occurred. The concern was that the patients could not actually tell the difference between good advice and harmful advice. The physicians identified a response as potentially harmful. Patients' ratings remained just as positive as they did before, as if the responses were actually safe. In other words, patients saw no meaningful difference between safe and potentially harmful responses. And why does this matter? Recognizing problematic advice often requires clinical knowledge and expertise that we should not assume that consumers have. And supervision is important. AI is a great tool, but healthcare professionals still need to provide supervision and guidance. And I just want to talk about one last study, and so we're shifting gears from AI to another very popular platform for online videos. In this study, the focus was understanding the quality of patient education available on YouTube. And the reviewers looked at videos related to home enteral nutrition and evaluated them using established tools to assess their quality and educational value. Over about 50% actually of the videos that they reviewed, and they reviewed 290 plus videos, scored really high for education content. And this is important because many aspects of home nutrition support a very visual procedures, techniques, equipment management can often be easier to learn when they're demonstrated rather than described in instructions alone. Here comes my but. The previous slides showed that many YouTube videos can be valuable educational resources. The next question is whether those resources perform equally well. And the answer is no. As you can see in this graph, videos produced by healthcare organizations, including hospitals, home care agencies, and academic institutions, consistently received higher quality scores than videos produced by independent content creators. The difference wasn't simply the topic being discussed, it was the quality, reliability, and completeness of the information presented. This finding, again, is very important because people often evaluate based on how professional it looks, how many views it has, or how confident the presenter is. However, those factors don't necessarily reflect the real quality of the education content. Um, the study suggests that one of the simplest ways to evaluate the video is to start by asking who created it. For clinicians, recommending trusted educational resources can help guide consumers towards content that is more accurate, reliable, and aligns with best practices. This slide brings those concepts I previously discussed together in a simple, practical framework. Regardless of where information comes from, you can ask four questions. Who created it? Again, hospitals, academic institutions have been shown to produce higher quality education materials. Is it current? Practices revolve over time. What was relevant even 2 years ago may not be relevant today. So make sure you look at something that is more current. Does it align with what your healthcare team has taught you? Your healthcare team knows you best. They can provide guidance that's pertinent to you. So follow those recommendations. Is there commercial interest behind it? If there's a sales pitch behind whatever video you're watching, this is a red flag. These questions won't guarantee that information is correct, but they can help identify resources that deserve a closer look and those that may require a little bit more caution. I've been talking about evaluating information, but ultimately the goal isn't for consumers to become expert at judging the website's videos and all the AI responses. Really, the best approach is to make your healthcare team be a part of your search. Ask your healthcare team which websites, videos, or educational resources they trust. If you find information online, bring it to your team and ask whether this applies to your situation. Over time, you can build a trusted list of resources together, and those resources can be used when questions arise. And for clinicians here, consumers are already using those tools. So this is our opportunity to prevent this is not a time to prevent them from using this, but to help guide consumers toward reliable sources that incorporate really good sources of information. If there's one message I hope you remember today is check the source, cross-check the information, and call your healthcare team with anything critical. And as I conclude, I'd like to leave you with 3 takeaways, which again, I repeated multiple times. AI and online videos can be useful educational resources. They're great. They have a place in healthcare and managing complications. Always consider the source and quality of information before acting on it. Only because somebody appears confident on the video that you're watching and seems like they're credible doesn't mean they are. And your healthcare team remains your most important resource for questions about your care and complications. Okay, that is all I have. Thank you.
Wow, thank you, thank you so much, Elena. I think those the actions uh, to know what to do, those steps when you're doing research are incredibly important. And I was wondering, what do you make of the fact that ChatGPT does well with empathy? What do you think that says?
Um, and when I first read this, I was like, I don't know if this says, I mean, obviously ChatGPT is great, but it almost makes me wonder, do we as clinicians need to do better? Because why is a ChatGPT doing better than human beings and at providing answers that show a lot of empathy? I don't know enough about how AI programs are built. So I'm not an
Right.
expert here, but like I said, it can be very misleading because it's such a great cheerleader. Um, we took on a house project because it told me we can do this. And I know that this provided questions to some medical answers to some medical questions that people in my life have had, and I have looked at those responses and been like, oh no, this is wrong. So while I think since it presents everything with such enthusiasm in a way, and it's like there is certain authority and like, yes, this is accurate. Not everybody can catch the fact that not everything it says is accurate because of the way it's presented. But again, it leaves a challenge for clinicians. And maybe we need to show more compassion than an AI chatbot.
Very good. Very good. Yes. So we have one more question for you, and I'm going to turn back to Vanessa. So the question is, what would necessitate usage of a line repair kit?
Usually when there has been a damage to the line, and whether it can be repaired or not really has to be determined by a physician. Some lines can be beyond repair, and that's one of those situations where obviously there's damage, like depending on the line you have. Usually it's silicone Broviac and Hickman that I've seen repair kits for. Depending on the extent of the damage, where the damage is, it may be able to be salvaged, but it is for line, usually breaking. It's specific parts of it that can be repaired. Mm-hmm.
Very good. Thank you. So, so Vanessa, I'm going to turn back to you for a question here is before we wrap up. And I think there was a little bit of an issue seeing when you were showing the filter before, so maybe you could come back to that. And we're not sharing our screen anymore, so hopefully that will automatically spotlight in the video. Can you talk about clearing bubbles from below the filter and when you need to worry about the amount of air that's in there, when you need to worry about that?
Yeah, definitely. Those are great questions. So first I'll address the amount of air. There's no like set in stone how much air is too much air. Generally, little champagne bubbles will be, as long as there's like a couple of them. You don't want a big bubble because what happens is as your body gets these air bubbles in it, if it gets a little tiny champagne bubble, your body is good at attacking things and breaking it down, and it'll break those down. Okay. But the problem that we see is sometimes patients can have like a hole in their heart. It's called a PFO, patent foramen ovale. And some people might not know, and that can be a little concerning. But for the most part, those little champagne bubbles are going to be just fine. If you do know you have a PFO, definitely pay more attention to those air bubbles. But I will say that everyone's going to be a little different. Some persons they're bigger, they're smaller. So we just like to err on the side of caution and say as little air as possible. So like I mentioned, there are a few things that you can do to prevent air past the filter, because as long as this filter is primed properly, it will push any air bubbles out of it. Okay, and similar to other air filters as well, not just this one. Okay. But if you've primed your tubing completely while your TPN is cold, that TPN that's now in this end tubing can break up and have those little air bubbles. Okay. So don't prime your TPN while it's still cold. Wait till it's at room temperature, then prime. That way the formula that's in here, that TPN in the tubing, is going to be warm and won't break off and create those little air bubbles. Okay. So again, let me just kind of show, and I hope my screen is bigger now as I'm talking and people can kind of see me. You can yell in the chat if you can't. Maybe Michael knows some magic, but here, I'll go ahead and show one more time how to
Maybe
prime
you
this.
can spotlight her, Michael, again.
Yeah, we'll give that a shot. Thank you. Let's
Okay,
see.
so if I kind of moved my setup around. Oh, there we go. I look super
Okay,
big.
great.
So if you have your pump kind of sitting on the table here and you have your tubing that comes out and you just kind of hold it up like this. So you have one hand priming it and one hand holding the filter upright so that arrow points up. Okay. So then I'm going to go ahead and I'm just going to prime. Okay. And my filter did empty because I showed you how it was bolusing. So you might be able to see.
Pull back just a tiny bit. It might be better if you pull back.
Can you see?
Yes, right there. Yeah,
If you can see,
still a little bit
my
hard to see, but it's
filter,
better. Yep.
the filter is filling. I wish I had like some brown fluid or something.
Hmm.
So my filter filled completely now. Okay. Now this is the key. If I were to connect this to my body, we're all good to go. This filter is still full, but my slide clamp is open. If I went about, and was grabbing other things and carrying my pump around and doing all sorts of things, this filter can start to empty. You might be able to see it. Maybe. Can you
It's
see?
subtle.
I'm just starting to empty right
Yep.
here. You see the fluid going down very slowly. Okay. And it might even drip out the end here, but that's bolusing. So if you come back to your filter at any point and you're like, it's empty now, what happened? That's why. Make sure to close your slide clamp before you jostle things around if you're not going to connect right away. Okay.
Very good.
Hey,
And you mentioned priming the tube slowly, and the question is, can the rate for priming be adjusted?
I don't know about other pumps. I know the Curlin pump, it cannot. But the rate that it primes at is sufficient. It's not going to cause extra turbulence through the tubing. Okay, that's something that we check for. I'm more concerned if you're like in a hurry and people grab their bags and they squeeze it and
Hmm.
they hold their little, if I pull out my little free flow protector here, I pull this out and I'm like in a hurry and I'm trying to go fast. You can even see it. It did that. It made a lot of air bubbles. So that's where we're more concerned is if you're in a hurry and you're trying to get it primed quickly, you're going to actually create more air bubbles doing that. And then you're going to be playing with your pump more. So trying to save a few minutes of time by priming quickly will probably add up later on down the road. So if you're using the pump, you're good to go. Okay. But if you're priming manually, just don't try to squeeze and force that through.
One more question as we wrap up here. What is the future of portable infusion pumps? How close are we to programming pumps on our smartphones, muting alarms on our smartwatches, etc.?
Oh man, isn't that the golden question, right? I know. And those diabetes pumps, they're so cool and they're so small and they connect to your smartphone and everything. It's great. I will say that that is the future, right? That's how everyone's going. Things that, can be programmed and smart pumps and you can be, your doctor can be, or your pharmacist can be here and you're at your house. There is always a concern about programming the wrong thing or giving the wrong thing or someone else getting access to that data. Okay. So we always want to be careful with that and make sure that that signal between wherever your provider is and where you are is going to be strong and it can't get intercepted. So I do know that that's the way of the future. Are we there yet? Is anyone there yet? I'm not sure. Those diabetes people, they definitely seem to have a leg up, right? But I will say that's something that everyone is looking towards. Yeah.
Very good. And any thoughts on manual priming versus with the pump as we wrap up here?
Yeah, so manually priming is great. It does go a little faster sometimes. Just be careful that you're not trying to prime too quickly, okay? And I know sometimes people don't like holding the button, and there are some other pumps where you just press it and walk away and it'll prime on its own. Just what's going to work best for you. So I know there's some people like priming on the pump, some people like manually priming, whatever is going to work for you as long as you're being safe and you're doing it correctly.
Thank you. Thank you so much, Vanessa. Thank you again, Elena. If you have any questions or comments about the program or anything else, you can reach out to Nutrishare and myself at patient support at nutrishare.com. You can reach out to Moog at clinicalsupport@moog.com, MOOG.com. And please watch for more information from us on our next webinar scheduled in September on the topic of what's in your go bag, preparing for emergencies. And quickly, since this is our last webinar before the Oli Foundation Conference in July in Madison, I want to remind those of you attending that many members of the Nutrishare team will be there, and we look forward to connecting with you, and the Moog team too. We'll be located at booth 8 in the Experience Expo. There'll be an event for Nutrishare consumers on July 12th, the Sunday. And as I mentioned, Elena is presenting twice. She's co-presenting a roundtable with myself and Nutrishare's clinical nutrition manager, Larissa Gogurich, on Sunday at 3:30. Speak Up, Be Heard, Advocating for Yourself in Complex Care. And on Monday at 9 a.m., she'll be presenting a breakout focusing on G-tubes with Kelsey Griffin, Nutrishare's Director of Patient Onboarding and Nutrition. Hope to see you all there. Thank you all for joining us today, and we'll see you again soon. Thank you, everyone.
Thank you.
Thank you.